snoring and health problems. You hear a sleep physician and upper airway physiologist called James Tredello giving a presentation about snoring and its links to health problems. You now have 90 seconds to read questions 37 to 42.
Hello, I'm James Tredello, a sleep physician who specialises in upper airway physiology. While snoring can be frustrating for those who have to listen to it, it is also known to contribute to a range of health problems. There's now also an emerging line of research that suggests snoring may directly contribute to serious cardiovascular health problems. When we go to sleep, the muscles of the upper airway relax, causing it to become floppy and partially collapse. This occurs to some extent in all of us. However, in some people the airway is excessively narrowed, particularly at the level of the tongue and uvula or soft palate. As we breathe in, we produce suction pressure to draw air into the lungs. This further narrows the airway, similar to when a person sucks too hard on a straw, and can cause upper airway tissues such as the soft palate to vibrate or flutter, similar to a flag in the wind. This movement creates the noise of snoring. There are many triggers for snoring. If a person doesn't normally snore, alcohol can be a key trigger as it blocks the nose and can contribute to relaxing of the airway muscles. And if a person already snores, alcohol is likely to make their snoring a lot louder. Being overweight increases fat around the neck, compressing and narrowing the throat. But thin people do snore too, and many who are overweight do not. A blocked nose, due to a cold, allergies, polyps or anatomical abnormality, creates the need for greater suction pressure to draw air into the lungs when breathing, which further narrows the airway. Mouth opening often occurs when the nose is blocked during sleep, which itself can cause snoring, via airway anatomy and pressure changes. Sleeping on the back contributes to collapse of the airway, as gravity pushes the tongue and soft palate towards the back of the throat. Enlarged tonsils narrow the airway and are a primary cause of snoring in children. In terms of the effects that snoring can have on a person's well-being, it can create a dry mouth, sore throat or headache, and can leave a person feeling tired. It can place significant strains on personal relationships, particularly a person's bed partner, but also those sleeping in an adjacent room or even sometimes on the other side of the house. Snoring forces many couples to sleep in separate bedrooms, disrupting intimate bonds. Snorers are often embarrassed to sleep among others, promoting anxiety and hindering their social relationships. Sleep disruption caused by snoring can make someone and others cranky and irritable during the day, but also may lead to impaired memory, concentration and learning difficulties, and obesity and reduced immunity. More serious consequences include snoring as a possible marker for obstructive sleep apnea, a disorder where the upper airway repeatedly closes during sleep and breathing stops for at least 10 seconds at a time. Obstructions to breathing can sometimes last for more than a minute and occur over 100 times an hour, starving the body of oxygen and fragmenting sleep. Obstructive sleep apnea sufferers are often excessively sleepy and at greater risk of car and industrial accidents and cardiovascular diseases like high blood pressure, heart attack, and stroke. Over the last decade, research has suggested heavy snoring itself may be a direct cause of cardiovascular complications, particularly a condition known as carotid artery atherosclerosis. When affected by atherosclerosis, fatty deposits known as plaques form in the wall of the artery. Over time, they can cause the blood vessel to narrow and limit blood flow to the brain. One study has shown that snoring vibrations are transmitted to the carotid artery, which can damage its wall and lead to the development of atherosclerosis. Subsequently, snorers may rupture a formed plaque, resulting in pieces of the plaque moving through the bloodstream and blocking small vessels in the brain. However, additional research is required to bring further clarity to this hypothesis. Given the multiple causes of snoring, there are numerous potential treatments available that work for some people but not others. Recommended lifestyle changes that work for some patients may include avoiding alcohol before bed and avoiding sleep deprivation, losing excess weight, and stopping smoking. There are several medical treatments for snoring that require professional advice. If you treat patients that snore regularly, it is highly recommended they see a sleep and respiratory doctor for diagnosis and to determine the right kind of treatment.
That is the end of listening part C. You hear an interview with Dr. Kylie Munro, a critical care physician from the United Kingdom who's been treating Ebola patients. You now have 90 seconds to read questions 1 to 6. Today, we're speaking to Dr. Kylie Munro, a critical care physician from the United Kingdom who's recently returned from Liberia, where she volunteered to treat Ebola patients. Dr. Munro, can you tell us a little bit about Ebola and explain your reasons behind volunteering?
Sure. Ebola virus is a severe, often fatal illness, and without treatment, 9 out of 10 people who contract the virus die. Many from dehydration, hypervolemia from excessive vomiting, loss of nutrients due to diarrhea, internal and external bleeding, and sometimes kidney and liver failure. Aggressive medical care is really simple by modern medical standards. Saving lives might require as little as clean IV needles, fluids, and basic lab tests, things that are readily available in resource-rich parts of the world. And we have them at our disposal all the time. They're not considered fancy where we come from. But that isn't always the case in remote parts of Africa, where supplies can be scarce.
And how did the patients you were treating respond to your presence?
To give you some sort of idea of what we're dealing with, the first two patients I treated were a brother and sister. Both had developed Ebola symptoms, which often present like flu, with fever and pain. And straight away they fled to the bush because they were fearful of what might happen to them if they were treated. They were found quickly because they were too weak to run. But even with treatment, both later died. We need to remember in 9 out of 10 cases, the victim's family never saw their loved ones again. So the distrust about what we were doing wasn't entirely unfounded.
And is it true you had to wear a lot of specialised clothing while treating patients with Ebola?
Yeah, that's correct. It's a little beyond the traditional white coat a lot of patients associate with doctors in a hospital setting. I would wear my scrubs, then I would put on a pair of thick rubber boots that came right up to my knees. After that, I had to get dressed in a bodysuit, then 2 pairs of gloves, a face mask, a hood that covered my neck, and finally goggles. The overall impression is similar to that of a spacesuit. You can imagine in the tropical heat and humidity, it was suffocating. You lose about 3 to 5 litres of sweat and then spend the next 2 hours hydrating before you can go back in. It does limit the level of care you're able to provide because it prevents you from having that physical contact with your patients, and that reduces the amount of sensory input we usually get as part of our jobs as physicians, but it also saves your life.
Can you tell us about one of the patients you treated while you were there?
Sure. One particular case involved a young girl who was part of a small cohort of patients we had to deal with, where someone in her family would be positive and someone else would be negative. And once a person was negative, they had to leave the unit. The little girl was 6 years old and she'd contracted the virus, but her mother had not. So I had no option but to escort her away. Both the child and her mother were terrified about what lay ahead for them. The girl died 4 days after they were separated. I think in some ways this example encapsulates just how awful things could be during this outbreak and the kind of personal tragedies that people had to live through.
Yes, I see. So you're back home in Manchester. When treating patients in the UK, do you think you approach your job in a different way because of your work in Liberia?
Absolutely. I do think it's made me sensitive to the limitations that are imposed on us, making sure that you've made a connection with your patient. One of the things we had to do for our patients in Liberia, in addition to just witnessing their illness and doing what doctors do around the world, which is to try and use medicines to blunt the worst effects of an illness, is also to try and help them manage their own anxieties and fears. I would like to think that I had been aware of it before, but now I think I understand the principle in an entirely new way.
And do you believe Ebola is something for the rest of the world to be concerned about?
Well, I know the disease has spread further, and I'm not surprised. In a recent case in Nigeria, a man infected with Ebola collapsed at a crowded airport in Lagos, its busiest city. He later died, and now authorities are closely monitoring up to 59 people he might have come in contact with. The majority of people think that Ebola is a dramatic disease that kills people in no time. The reality is that the incubation period is 21 days, and because the disease can spread from an infected person to another person via direct contact with blood or body fluids via the nose, mouth or eyes, or even from open wounds like cuts and abrasions, the potential for spread outside of Africa is there.